Dr. Shivaputra L. Balareddy. It's my honor to introduce a distinguished personality in the field of Ayurvedic surgery. He is currently serving as professor in the Department of Postgraduate Studies in Shalya Tantra at BVVS Ayurvedic Medical College, Bagalkot, Karnataka. Please join me in welcoming Dr. Balareddy. He'll be speaking on the topic do's and don'ts in general practice. Welcome you, sir.
Good evening, everyone. After hearing two vastly explained beautiful talks, it will be difficult to have the attention of the audience. Even then, I'll try my level best. Basically, in anorectal diseases in general practice, there are so many myths and mismanagement. So, just I wanted to highlight on basic what should not be done more. What should be done, majority of the classes will tell. So very commonly we come across in general practice is very commonly fissure in ano, hemorrhoids, perineal abscess, fistula in ano, rectal prolapse, and rest are rare conditions. Very commonly we come across these diseases. In the general practice, majorly people come and approach the general practice, and majority of the people in the area where I practice, they come with some either the pain or the heat, something. There are so many different words they explain. So majorly fissure in ano is the very common condition which approach to the general practice and commonly said heat aget nodri, they say that pain and burning sensation. Very commonly, and acute fissure in ano and chronic fissure in though this thing, majority of the thing culprit is one hard stool passing or the secondary to the GE, the fissure in ano starts. Majority of the time we don't ask the history. That is the thing. Basically, females, both anterior and posterior fissures are common, and in males we see majorly posterior fissure in ano. Next slide, please. So the bleeding will be very streaky and painful defecation, and after defecation there is a pain. So this is the history you need to well. Next slide, please. So what should be done as a general practitioner? What should be done? Let's use high fiber diet, educate the patient, stool softener, and analgesics. Ayurvedic medicines like there are so many proprietary medicines are available. Basically, the stool softeners and laxatives are there, and wound healing agents, seeds bath. And my request to all the general practitioners, no roll up antibiotics or the B complexes, which we copy from modern physicians and surgeons, majority of them prescribe. That is actually absolutely there is no role. And no saline or something is going to help the patient. So you want when to opt for a surgery. So even after 2 weeks of the conservative management, if the patient doesn't get relief pains, review the patient with all the prescribed medicines. Because majority of the patients comes to us, sir, na medicine togondri eno agilri. And sometimes they take 2 days medicines and they expect 100% result. So always review with the prescribed medicines, and if the pain is increased, then give the option for a surgery or put a second line of medicines. Second line means higher analgesics. And the standard surgical treatment is lateral internal sphincterotomy, and large anal dilatation is already outdated now. And especially no role of Kshara or Kshara Sutra here. If somebody is advising or doing, please don't do in a fissure in ano. Okay, so these are the fissure in ano, the two different patients. These are the two fissure in ano. In such cases, next slide. This is the lateral internal sphincterotomy, what I have done. This is the internal sphincter, what you are seeing in the artery forceps and after the sphincterotomy. So this is the one procedure. Even you can send the patient on the same day. So this will help the patient to come out of this bridge. And next slide. So the next slide, we'll go ahead with the hemorrhoids. Very commonly we come across with the types of hemorrhoids. I need not have to repeat. Primary and secondary hemorrhoids. In this, the one image, it has both primary hemorrhoids and secondary hemorrhoids, both. Okay, next slide. See, that is the second, the first left one is the second degree hemorrhoid. When the patient strains, he bleeds and it goes back. And grade 3 is it doesn't go back. That is the fourth one. The last corner one is the prolapsed thrombosis. Such worst condition, such condition, the patient comes to us. Till then, they will be treated by the general practice. They will be with your hands. So, at least once you try and see the correct leg. If you cannot do the digital examination, at least see their bottom. Is there any swelling or is there any abscess? Is there any opening or anything? So at least once you try to see. Hemorrhoids usually the painless bleeding, prolapse, and pain. Usually pain will not be there. Only if there is any thrombosis, then only the patient will have the pain in the case of the hemorrhoids. Mucus discharge and pruritus and all with the things. But go back. So the medical management in a general practice perspective is cold or warm Siddha baths. Cold Siddha bath, when the prolapsed thrombosis is there, prolapsed thrombosis piles are there, go for the ice pack or the cold Siddha bath. But rest of the conditions, you need not have to go for a Siddha bath. Only if there is a pain, go for the Siddha bath. Otherwise, no Siddha bath. And soothing agent, topical anesthetics, creams, analgesics, anti-inflammatories, and especially no antibiotics. Suppositories doesn't help more, and laxatives, vasoconstrictors, and antiseptics. All these are the things. You should make a rule, and always go for the history and go for the, always high fiber diet is advisable in all the cases. Next slide. And parasurgical treatment is Pratisarani Akshara, Agni Karma, sclerotherapy, cryo, rubber band ligation, radio frequency. Nowadays we are doing dizzy hall and laser ablations. All these things nowadays are available. They are all parasurgical. There won't be any surgical intervention. There will be parasurgical. So this is the classical prolapsing thrombosed hemorrhoid. This is the operative treatment is hemorrhoidectomy, minimal, that is a stapler hemorrhoidectomy, hemorrhoidepexy. This is what I have done is the prolapsed thrombosed hemorrhoids. I have done a hemorrhoidectomy. These are the hemorrhoids and post-op. So go. Things to do in a GP. What to do? Ask complaints and history in detail. If possible, do PR examinations. Mild to moderate laxatives are recommendable. Advise high fiber diet, regular analgesics, Siddha bath if there is a pain. If there is no pain, no Siddha bath. Soothing creams, ointments for local Thaila pichu or Grita pichus are works. Suppose it is not promising results. Anti-hemorrhoidal Ayurvedic drug, there are so many proprietary medicines you can go ahead. And nowadays there are so many modern allopathy pharma companies of prescribing extract medicines. So like there are Euphorbia prostrata, Draksha, so many drugs are available. They are promising now. They are advisable. Better not to advise is folk treatment, sphincterolysis, sclerotherapy, unnecessary diet, local injections, so many things. So these are not advisable. Please don't go for any sclerotherapies, injections, so many things. So that's not. And the next condition, very common condition which come across in the general practice is perineal abscess. And a majority of the things are being given injections, medicines, antibiotics, and everything. But very commonly these are the types where the multiple types, 5 types of perineal spaces, they develop the abscesses. Evaluation, no specific investigation is required. Here is, it requires, if it is uncontrolled or if it is non-evaluated, go for evaluations. Management of perineal, mainly surgical treatment. Don't keep the patient by giving injections and antibiotics and the painkillers. See if there is any swelling, send it to the surgeon so that it can be drained. So that this can lead to the Fournier's gangrene, fistula, and so many complications. Go for next slide. This is the perineal case of abscess. The 2 cases, different cases. Next slides. Both the cases which operated and draining. This much of the draining. Why draining? With the finger you can break all the localized. With the scoop you can drain all the granulation tissue. Then only it will heal. Otherwise it will end up, patient will end up in a fistula. Next slide. So please don't attempt abscess puncture by the needle. In the majority of the general practice, they puncture with a needle. Don't do it. Aspiration abscess. Syringing, they do aspirate it. Please don't do it. Small nick up and on abscess. Full blown abscess, they put a small nick. Only it will drain liquefied abscess, but the solid debris remains there only, so that has to be removed by the surgical only. So extensive abscesses may lead to complications like Fournier's gangrene, circumference oblique shock or septic shock. Next slide. This is one of the case which I operated in the last week. Fournier's, this was neglected or over managed by the GP with the perineal abscess. Patient landed in a Fournier's gangrene. I had to operate in last week. I operated him in septic shock. So these are the, if you neglect these things, so such things happens. So this is primary perennial abscess with primary threading. Means internal opening with the threading is good thing. Next slide. So left with the xaros or the new thing which we are doing nowadays. Next slide. So perennial hematoma. Here is the condition. You go for the ice packing and a sitz bath, cold water sitz bath. If you give the hot water sitz bath, it will enlarge more. You will have to, patient will come for a surgery. If you give a hot water sitz bath, patient comes to the surgeon. If you give a ice pack, patient will get relief. Next slide. This is the rectal prolapse which needs a surgical attention only. Only when nowadays we are doing the XAR application, XAR karma. So this is the polypectomy which I have done. Rectum, see, go back. Intestinal perforation, massive bleeding, with these things, please, here rectum patients comes. Please don't neglect with the constipation, any constipation or the defecation, straining during defecation, if the patient comes, always evaluate it. Next slide. These are the CA rectum cases which we took biopsy. If the CA is diagnosed, this is the fate of the patient. Everywhere it will be dragged. So that sir has told. See, there is no absolute role of antibiotics in the anorectal disease. Only there is abscess or fistula. Otherwise, no role of antibiotics. Has a good role in abscess. Is there any role of B complexes or multivitamins? Absolutely no role of the B complexes or multivitamins. Only in a convalescent period of the postoperative period. Otherwise, no. Is there any role of steroids? No, absolutely no. No steroid role has there. Because if the GPs are prescribing, only neuropraxia is the condition where you need to go for the steroids. Otherwise, no. So, judicial use of NSAIDs is recommended. Before prescribing, keep in mind that whether the patient is diabetic, hypertensive, IHD, COPD, all these things you should be keep, because nowadays we are seeing CKD, chronic kidney disease, are very common in rural areas. I don't know what is the thing. So always use judicial NSAIDs. Sitz bath, don't advise all the cases sitz bath. And how much sitz bath? At least 10 minutes. How much temperature it should be? It at least a lukewarm water, it can be tolerable temperature to take the bath. And the temperature should remain 10 minutes. Majority of the people, they sit and keep quiet for 10 minutes. No, at least they keep on getting the top up of the warm water. So then only the same temperature should be there for 10 minutes. So nowadays, because of the mobile, people are not sitting for 10 minutes. So ask the patient to have 2 songs. Till then, he completes the 2 songs in the mobile, then only he will come out. So that is the thing you need. Should not be used as Savalon, potassium permanganate, Dettol and sanitizer, because all these things excoriates the skin, which majority of the GPs prescribe a Dettol hakon kudri niraga. So if you use the Dettol, skin excoriates, patient will come to the surgeons early. So always use a Panchavalkala Kashaya or Betadine or any filtered Kashaya. Next slide. So when to refer, whom to refer? Whom to refer is, it's your discretion, but at least my request is to send the surgical cases to nearby Ayush surgeon or the Ayush college, so that you can help your own system by referring it to the Ayush systems. So take home messages, interact with the patient properly, give the treatment with a symptom centric or the patient centric, refer the case to at the proper time, educate the patient for needed lifestyle changes, prescribe antibiotics when it is absolutely necessary, judicial use of antibiotics, and uphold the Ayush system by referring to the nearby Ayush surgeon or the Ayush colleges. So that is my humble request. Thank you all for giving me an opportunity to speak in front of you. Thank you.
Thank you for the wonderful session, sir. Next, on the dais, we have Dr. Srinivasa K. Bannigol, Chief Administrative Officer, Sanjeevani Ayurveda Mahavidyalaya, Hubli. His excellence has been recognized with awards like Shushruta Award, Dronacharya Award, Agnivesh Vaidyaratna, and Suvarna Sadakaru 2024. We are indeed grateful to have you here, sir. Over to you. He'll be speaking on the topic parasurgical procedures as daycare procedure. Over to you, sir.
Good evening to all of you. Today I will be talking about daycare procedures which a general practitioner can adopt in a single one OPD setup. Dr. Pradeep has already enlightened you regarding the Panchakarma procedures wherein a general practitioner can perform in a very small setup. You know, in Ayurveda, Panchakarma and Kshara Sutra are now globally accepted. And we have to encourage our general practitioners to practice even in their, at the OPD level as a daycare procedures. So today I am going to concentrate on what is the daycare procedure, what are parasurgical procedures which can be managed as a daycare procedures, brief description about the parasurgical procedures, brief description of the diseases fit for a daycare procedures, and demonstration of few parasurgical procedures which a general practitioner can easily practice. Next slide, please. As all of you know, the surgical practice, even though Sushruta was considered as father of surgery, his last option was the surgery. Earlier, he used to use medical treatment, paramedical treatment. If not, then last option, he used to go for the surgical procedure. Now, the surgeries are categorized as conventional surgeries, which are invasive. Now, we have come to laparoscopic surgery, where the minimal invasive procedures are there, non-invasive like laser surgeries. So surgeries is changing from one decade to another decade. Next. And what are the daycare surgery? Daycare surgeries, we are performing the surgery in the morning and discharging on the same day. This is ambulatory surgery. Two ambulatory discharge within 6 to 8 hours, and extended ambulatory discharge within 24 hours. So altogether, we can call it as a daycare surgery or a OPD level surgery. Now, if you want to practice a daycare surgery, there are certain SOPs, standard operative procedures, are to be followed. First thing, after clinical examination in OPD, the diagnosed cases shall be selected for the daycare procedure. Now you have to select whether this particular disease or a patient is fit for daycare or not. When you say it's a fit for daycare procedure, minimum investigations are required, like a complete blood picture, HIV and HbSAg are mandatory nowadays. Random blood sugar, if you feel that the patient is diabetic, that has to be continued, and you have to take a written consent. Give injection TT prophylactically and xylocaine test dose if you are performing the procedure under local anesthesia. Then perform the procedure without anesthesia or as a local anesthesia maybe. Observe the patient for 1 hour, and then you can send the patient for home, advising the post-operative treatment, how he has to follow the post-operative treatment. Ask the patient to visit OPD for the follow-up. As the case may be, next day or after 1 week, you have to ask the patient to come. Continue the treatment till the complete cure of the disease. So these are the certain standard operative procedures one has to follow if you want to perform a daycare surgery or a surgery at the OPD. What are the advantages of daycare surgery? There's an early mobilization is there. You do the surgical procedure, send the patient back home. Shorter hospital stay, back in comfortable and homely atmosphere. Patient wants to go home at the earlier because he feels he's very safe and homely atmosphere he likes. It's a cost effective, as well as it reduces the risk of hospital acquired infections. Now, the diseases are broadly classified as Snehadi Kriyas, that's the medical management diseases, surgical management diseases. Coming under the surgical management diseases, we have got Shastrakarma and Anushastrakarmas. Shastrakarma, conventional surgery. Anushastrakarma is a parasurgical procedure. So in parasurgical procedures, today I am going to concentrate on 3 main parasurgical procedures. There is Sharakarma, Agnikarma and Raktamokshana. Next, please. The diseases which can be treated, which I give, there are a lot of diseases are there which can be treated as a daycare or at a OPD level surgical procedure. I am concentrating only on few diseases wherein a general practitioner can practice. That is the Bhagandara, the fistula in ano, Nadi Vrana, a type of, it's a sinus. Commonly we encounter in surgical practice the pilonidal sinus. There's a Korn, there's a Kadara, Arsha, there's the hemorrhoids, Vrunashota, inflammation, Dushta Vruna, there's a chronic wounds. These can be practiced as a daycare procedure under this thing. Bhagandara or the fistula, as you know, I am not going to in detail about the description of the diseases. It's a chronic inflammatory condition. There's an sinus is there which is communicating with the anal canal, that is called as an fistula and ano. Next slide please. The clinical feature, there's a discharge in the perianal region. pus discharge from the anus. Sometimes pain and discomfort will be there. And history of pain is unique. Whenever there's accumulation of pus is there, patient has got the severe pain. When the pus drains out, pain subsides. On examination, we can do the digital examination, do the probing and find out the direction of the fistula and ano. So diagnosis of fistula and ano sometimes is very difficult because a lot of offshoots and ramifications will be there. And it is told that, next week, it is told that sometimes finding God is easier than exploring the fistula. This is only for making you aware that the treatment of fistula, even though I say it can be done as a daycare or general practitioner, but still a lot of difficulties are there. We have to follow the good science rules to find out the direction and depth of the fistula tract. There's anteriorly, within 2 centimeters, there will be a straight track. Otherwise, posteriorly, curved track will be there. Next. So these are the various pictures of fistula and pictures where there's an external opening in there. This is the rectovulval fistula, very rare case. Next. The materials required is a local anesthesia. All these things need not there. You require a probe, local anesthesia, and a HR sutra. The patient in the lithotomy position, we have to again give the local anesthesia infiltration, put the probe and see the direction, take out the probe from the internal opening, then tie the Kshara Sutra, not too loose or too tight. This is a procedure. I am doing the probing. Then probe is taken out. It is with the Kshara Sutra, it is taken out, it is tied. For a general practitioner, there are types of fistulas with the low anal fistula and high anal fistula. As a daycare procedure, as a general practitioner, don't practice high anal fistulas. Only low anal fistulas when you are very confident that the internal opening is below the dentate line, then you can practice. Next. 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 This is what previous. This is what the case was ligated and it is completely cured. Next. Next. Pilonidal sinus. Next go. All of you know. Clinical features, everything. There's a sinus in this thing. This is a video where we are ligating the Kshara Sutra, giving the local anesthesia, infiltrating the local anesthesia. Sinus, as you know, is one opening. We have to create another opening because almost the tip is coming out from the skin. It's completely healed. And in the pilonidal sinus, there will be cleft of hairs. So that is an infection foci. They have come out first time we take out the thread. Archas by Agni Karma, next time going to do in hemorrhoids, in external hemorrhoids, we do the Agni Karma. Next. These are the Agni Karma Shalakas. Dr. Arjungi, Santosh Arjungi has developed this Agni Karma Shalakas you can have. And now this is a external sentinel mass wherein we can do Agni Karma and remove the track. Advantages of Agni Karma. Next is in Kadara, we are doing Agni Karma. This is the Kadara, you know, small heart swellings in the soul. Description of Kadara, no. This is a procedure of performing Agni Karma with Dagda Shalaka and local anesthesia. So it is after 15 days complete, it is healed. Next. Last procedure I am going to is the Rakta Mokshana, that is by Jalokas. Next. You know, all of you, Jaloka Ucharana, I am going to highlight. So these are the Jalokas. They suck the blood. Nirvisha Jalokas are used for Rakta Mokshana. These are the external thrombose or inflamed pile masses where we can apply the Jalokas. Next. This is the thrombose mass. Next. We have applied the Jaloka there. Next. This is another thrombose pile mass. Next. Application of Jaloka in the area. Mode of action, as all of you know. Next. In Dushta Urunas or Runashofa, inflammation, Runashofa, they are very useful. These are the Dushta Uruna, we applied the Jalokas. It's completely healed after this thing. Along with Jaloka Ucharana, we have to give internal medication also. In Sandhishota also, we are using Jalokas. Next. Jaloka Shodhana has to be done after performing Jaloka Ucharana. Next. So, there is a lot of scope for the general practitioners to practice these parasurgical procedures in their own clinic at their OPD level. Dr. Pradeep has given you a highlight on how, OPD level you can do the Panchakarma procedure in the same way. Parasurgical procedures, the Anushastra Karmas, can be very easily practiced by general practitioners in their small setup of clinics. Thank you, one and all. Thank you for the AYUSH TV and AFI for giving me the opportunity to share my experiences with the August gathering. Thank you, one and all.